My name is Cassandra Snyder Wyatt. Today is September 30th, 2019. I am a 7th semester nursing student here at Lincoln University, and today I will be demonstrating how to insert a nasal gastric tube down somebody's nose and into their stomach, how to give meds through that tube, and how to take that tube out. Just continue it with a physician's order. So at this point, I've already gathered all of my supplies. I've already come in and I've assessed my patient. I've talked to Mr. John Jones here about how he can help me with this procedure and assessed his level of consciousness. I've assessed whether he's had any kind of nasal surgery, if he has a deviated septum. I looked in his nose with my pen light and decided that I'm going to use his right ear due to his deviated septum over to the left side. And I've raised him into high fallers. I'm going to raise his bed to a working height. Yep. Alright, I provided him with some patient privacy. I'm going to wash my hands. I've identified him by his name and date of birth. And we will go back through how to help me with this procedure here in a minute. I'm going to put a towel on him so that if I get any kind of gastric secretions, I don't get it on his clothes. And I'm going to put some gloves on. Let's show you my assessment of his nares here. And as I said, he's got a deviated septum, so we're going to use that right nair. You can also have them show you the patency of their nares by like taking a deep breath in a nose, blowing a nose, just to make sure that you can as easily as possible pass that tube through their nose. At this point, I'm going to go ahead and open up my nasogastric tube. Grab my tube. I'm going to wrap it around my hand a couple times, bend it, just because this tube comes really stiff in the package, and I want to make this procedure as easy as possible for my patient. At this point, I'm going to take the tip of my tube, put it on the bottom tip of his nose here. I'm going to measure it from the tip of the nose to the earlobe, and then from the earlobe down to the end of the xiphoid process. And 45 centimeters is about where we're going to insert this tube. I'm going to take a piece of tape, wrap that around my tube, so that I know that's where I need to position my tube. I'm going to lay my tube here in my lubricant. I'm going to put some lubricant on this package here. I'm going to lay it in the lubricant while I tear off some more tape for the procedure here. I am lubing the tip of my tube about 4 inches here. I'm going to tear off 3 more pieces of tape. I'm going to tear off one piece to help me with securing the tube to his cheek later on. I'm going to tear off a piece to fully secure it to his nose, and then I'm going to tear a piece to put on the tube and be able to secure it to his gown. At this point, my tape is ready. Mr. John Jones here is ready. I have some water here at the bedside. I'm going to give him a pan in case he vomits, because I don't want that to get on the bed. If it does, it's okay because I can change the bed, but we're going to do everything to prevent that. So at this point, like I said, I lubed my tube 4 inches, and we're going to get ready. Okay, Mr. Jones, remember, I'm going to have you tip your head back, and then whenever I advance the tube and I'm ready to go down the back of your throat, I will have you put your chin to your chest and take a few sips of water. But anytime you need a break, just let me know, okay? Alright, so I'm going to make sure that my tube is pointed down here. I'm going to go ahead and advance it. Great job. I meet resistance, so I'm going to turn 180 degrees and have him tip his head to his chest and take a few sips of water. I would like to have an assistant, like a CNA or another nurse. And as he's taking sips, I'm going to advance 2 to 4 inches, take another sip, advance, take another sip, advance, take another sip, advance, and continue to do so all the way until I meet my mark. If at any point my patient was in respiratory distress, I would go ahead and pull that tube back out because I'm probably in some kind of some point of the respiratory tree, and I'd give him a break, and then we would go again. I'm gonna, like I said, temporarily secure this to his cheek. I'm going to check the back of his throat. I'm gonna use my tongue depressor. Make sure that I have not coiled this in the back of his throat, which I have not. It is hopefully down his stomach. If my tape was not sticking to an actual human, I could wipe their skin with like an alcohol swab. We've tried to do that with this mannequin, but the tape just doesn't stick. But in real life, you would want to make sure that it does stick. At this point, I'm going to go ahead, depending on my facility's policy, I'm going to listen for a swoosh of air in the stomach to check placement. I can get an x-ray, or I can pull gastric contents and check it on a piece of pH paper and check it that way. My facility's policy is to listen to a whoosh of air. I'm going to instill 30 mils of air. I have my tube here. 30 mils of air into Mr. Jones's stomach here, and listen for a swooshing sound. And I heard it. So it's in the correct place, so I can take this off. I can clamp the tube. I can put the air vent on it, however you prefer. At this point, I'm going to go ahead and actually secure my patient's tube to his nose here. You want to be really careful whenever you're doing this not to pull the patient's tube out. I'm doing my best not to pull his tube out here, or to like rest my arm on his head, which is easily done. I'm going to take this little piece of tape off. I can move this towel. At this point, I'm going to grab my other piece of tape. I'm going to make a flag out of my tape here. So I'm just going to put it on the tube and push it together. Grab my safety pin. Stick it through my flag. Put it on the patient's gown. I would have him, he's mannequin so he doesn't turn his head, but human, I would have them turn their head. I want to make sure that this patient can move his head every which way that he might move it before I secure it, because you don't want to secure it super tight. Like this probably actually is fairly tight. And then him turn his head to look at a family member and like rip that tube out. That would be traumatizing. So at this point, I said my placement was checked. I can hook my patient up to his suction. I need this little piece. And then I would bring him back down, clean up my mess, and then go document how my patient tolerated the procedure, the size of tube that I inserted, the gastric contents and their characteristics whenever it came out of the tube, and take off my gloves, make sure I perform hand hygiene, and we're going to go ahead and assume that this is the next day. I'm coming in. Mr. John Jones needs some medication. We're going to put that in his tube and go from there. I am going to leave this towel here just because I know that my piston syringe leaks. It's a very well used syringe here at school, so so you go to your bedroom, you perform your medication checks, your first 2 checks in the bedroom, you crush your meds, you check the meds, make sure that they're not like extended release, that they can be crushed. Some medications can't be crushed. If you ran into that issue, you'd want to call the pharmacy and see if you can get like a liquid solution. Mr. John Jones's pills can be crushed, so I'm going to take my Silent Night, the pills, I'm going to put them in the package, crush them. They're crushed. You want to make sure that they're a fine powder that will be able to be dissolved. And then you dissolve them in 20 mils of sterile water. And this could be a fairly time-consuming process because you got to make sure that the medications are completely dissolved before you can do anything with them. So at this point, I know that my medications are dissolved. I can bring my piston syringe and my medications and all the sterile water that I will need for flushing into my patient's room. And perform my other medication checks here in the room. I asked Mr. Jones to identify himself by his name and date of birth. I raise him up to working height. There we go. Okay. At this point, I'm going to perform hand hygiene. Rub my hands together. Put some new gloves on. I'm going to disconnect my patient from his tube feed or suction. If he had a tube feeding, I would check the residuals or whatever my facility calls for, and then go forth by whatever the residual volume was and whatever the physician's order called for at that point. At this point, I'm going to go ahead and check the placement of the tube, ensure the placement of the tube. I heard the whooshing sound, so I know that the tube is in the correct place. I'm going to flush this tube with some water. About 30 mils. You want to make sure that you're not pushing this water into his tube super fast, or that it's a extreme temperature, cold or hot, because that can cause lots of stomach discomfort. Now I'm going to suck up my med. Like I said, this is dissolved in about 20 mils of water. And then, like, if you tipped over your medication cup or if you spilled lots of medication, then you would want to go crush another med and redissolve it, just to make sure that your patient is getting the full amount of his medication. Now I'm going to flush between his next medication with another 30 mils of water, 20 to 30. You want to keep in mind how much water you are flushing, because you need to document that later. I'm going to suck up my other med here. Make sure you get all of the medication. Like I said, I know this piston syringe leaks. This was the best one that we could find. If you had one that was like this in actual practice, you would definitely want to go get another syringe. This one's like leaking really bad now. Alright, now I'm going to get my last flush worth of water. Try not to make a mess. Here we go. Okay. Flushing this tube, flushing this tube. And then I'm going to leave his tube clamped at this time for about 30 minutes because you don't want to hook him back up to suction and then it suck all of those medications right back out. So I'm just getting this out of my way here. You would want to clean up your work area. Take your gloves off, bring your patient's bed back down, and then come back in about 30 minutes and then just reconnect into a suction. So Mr. Jones's therapy is complete, and it's time to remove this tube. We have, earlier today, we got the order that the physician thinks that he's ready for his tube to be clamped, so we clamped his tube earlier today. He has not had any nausea or vomiting since we clamped the tube. He's tried some oral fluids, no nausea or vomiting with that, so we know that this tube is ready to come out. So I've checked and made sure that there is a physician order for this tube to come out, which there is, and at this point I'm going to go ahead and bring my patient back up to me. I'm going to put a towel down just because I know from experience how pulling this tube out can bring some extra gastric acids and fluids and all that stuff out. I don't want that on his gown. So I'm going to go ahead and put a new pair of gloves on after I perform hand hygiene. And let my patient know what's going on. Mr. Jones, we're going to go ahead and remove your tube. I want to go ahead and check the placement of the tube. I can flush it with some water, some air. Check the placement of his tube by the whoosh, with a whooshing sound, and then flush it with about 10 mils of air. Disconnect his tube from his tube feeding or suction, which it should have already been disconnected from suction because I said that it was clamped. I'm going to listen. I flushed it. It flushed okay. Air. I heard the whooshing sound. Very close. Okay, Mr. Jones, ready for this to come out? So I'm going to disconnect it from his gown. Maybe take his tape off. And at this point, I would ask him to take a deep breath and hold it. Okay, Mr. Jones, take a deep breath and hold it. Hold it. I'm smoothly pulling this out. I'm going to wrap it up in my glove. I'm going to take my gloves off, throw it away, bring my patient back down to earth, make sure that I grab the suction canister. You want to do that with gloves on, but take out all the stuff that goes along with de-seeing a tube, and all the tubing, all the suction tubing, all that stuff, so he doesn't have to remember the procedure. And then you go document any extra gastric gas, any of whatever was left in the canister that has not been documented. That you discontinued this tube and how the patient tolerated the procedure.